Pediatric Nursing Certification Review Preparation Course. Chapter 2, Growth and Development by Jennifer Adams. Before becoming a nurse, Jennifer Adams was a child development specialist working throughout the state of Delaware to improve the quality of early childhood education and teaching child development. Since becoming a nurse, she has worked with children applying an understanding of child development to improve overall wellness. Jennifer Adams currently teaches pediatric nursing and continues to study development across the lifespan.
After completing this module, you will be able to assess the developmental level of a child, then plan appropriate interventions to optimize coping. This is important because planning and delivering family-centered care based on developmental needs leads to the best family coping and patient outcomes. Pediatric patients exist within the context of a family, therefore the family has to be included in all pediatric care. The family should be treated as a partner in care, should have access to all necessary information regarding the child, and should be encouraged to participate in decision-making and care delivery. Each family defines who its members are and can include anyone from blood relatives to friends to pets. Each family also has its own individual culture, which is a unique expression of their beliefs. The family's culture affects how they define wellness and what they believe causes and cures illness. Culture also determines how families communicate and make decisions about treatments. For example, a family may not implement recommended treatments because they are not congruent with their cultural beliefs. The nurse's responsibility while providing family-centered care is to be culturally competent, which means being non-judgmental and listening to and observing the family to understand their culture and providing care that matches their preferences and practices. The first step in planning developmental care is understanding the predictable physiological patterns of growth and development. Growth occurs in a linear fashion from head to toe or cephalocaudally, from the center outward or proxima distally, and from general to specific. Imagine how an infant develops motor skills. First, they learn to hold up their head, then hold things with their hands, then crawl, and walk. This is cephalocaudal development from head to toe. Now think about a child learning to write. As a toddler, the first strokes are big, broad scribbles drawn by moving the arm at the shoulder or elbow. As the child grows and matures, the strokes become smaller and controlled from the wrist. Finally, by the late preschool to early school age stages, the child can write clear letters by moving just the fingers. This describes proxima distal development from the center outward. Now think about a young child learning to categorize animals. In the toddler stage, all four-legged animals may be called by one animal name, such as a dog. As a preschooler, the child might be able to classify animals by cat, dog, cow, sheep, etc. But as an older school-ager, the child could identify dogs by their breed. This is an example of general to specific cognitive development. Although growth patterns are predictable across all children, the rate of growth and development is affected by genetics as well as environmental characteristics. Therefore, chronological age may not be the most accurate indicator of development. Chronological age describes the child's age in years, months, and days since birth. Chronological age does not always match bone or mental age. Bone age is determined by X-ray interpretation of the ossification of the wrist bones. Comparing bone age with chronological age can determine if a child is growing too quickly or too slowly. Mental or developmental age is determined by intelligence testing. Comparing mental age with chronological age can determine if a child has a developmental delay or is precocious. Because children born premature were not fully developed at birth, their chronological age is corrected when comparing their growth and development to children born full term. The number of weeks born premature is subtracted from the child's chronological age to determine the adjusted or corrected age. This correction is used for the first 2 years of the child's life. For example, let's say an infant was born at 28 weeks. That's 12 weeks or 3 months early. When the child is 9 months old, they may appear to be underweight, under height, and to have developmental delays if compared to an average 9-month-old. However, this baby was born 3 months too soon. Their adjusted age is 9 months minus 3 months, which equals 6 months. So this baby should only be compared to average 6-month-olds. When using the corrected age for comparison, this baby will appear to be growing and developing typically. Vital signs also follow predictable physiological patterns. The smaller a child is, the lower the blood pressure will be, and the faster the respirations and pulse will be. Respirations and heart rate should be counted for 1 minute because they can be irregular. Heart rate can increase and decrease with inspiration and expiration. The correct sized blood pressure cuff should be selected to obtain the most accurate reading. The bladder should cover 40% of the distance between the shoulder and elbow and 80 to 100% of the circumference of the arm. Cuffs that are too small will produce falsely high readings, and cuffs that are too large will produce falsely low readings. Temperature may be unstable shortly after birth, but is quickly regulated by healthy infants. At 4 to 5 years old, children should be able to lift their tongue for an oral temperature. Pain is a vital sign and is defined the same for children as adults, whatever the patient says it is. However, some children are nonverbal or lack the cognitive ability to quantify their pain. Pain scales designed for children should be used. Common manifestations of pain in children include crying, restlessness, and behavior changes, such as acting more withdrawn or irritable than usual. However, some children react very strongly to mildly painful stimuli, while other children may be afraid to show pain at all. The FLAC and FACES are two commonly used pain scales for children. With the FLAC scale, the nurse observes the child and assigns scores to the child's behavior for facial appearance, leg appearance, activity level, cry, and consolability. The FACES assessment is a self-report scale for preschoolers and older children where the child identifies a face that matches their pain level. The numeric and visual analog scales are similar. The visual analog scale is the numeric scale with the addition of a line from 0 to 10. The visualization of the line can help the child quantify their pain. Non-pharmacological pain interventions for children include developmentally appropriate distraction and comfort. Learning more about the development of children in this module will help you choose appropriate pain interventions. Height and weight are similar to vital signs in that they are indicators of a child's overall health. Weight should be measured with the child undressed or wearing the same clothing with each measurement. Children under 2 years old should be weighed on an infant scale, while children over 2 years old can use a standing scale. Length is measured with an infant or toddler lying down on a length board. Height is measured standing up for children over 2 to 3 years old. Head circumference is measured by placing a tape measure just above the child's eyebrows and encircling the largest part of the skull. Head circumference is an indicator of brain growth and should be measured until the child is 2 years old. Growth should be plotted on the appropriate growth chart for the child's age, gender, and method of measuring height. Children measured lying down should be plotted on the length chart, while children measured standing up should be plotted on the height chart. If the incorrect chart is used, the child could appear larger or smaller in comparison to other children the same age. Body mass index outside expected parameters should be investigated to determine if there is a medical, psychological, or social cause of the unexpected growth pattern. When a child's growth increases or decreases multiple percentiles in a short time, a cause should also be sought. The percentiles are the curved lines with the percentile ranks listed on the right of the graph. The last physiological patterns we'll review are the psychosocial and cognitive development theories. These are the stages of Erikson's theory of psychosocial development. In each stage, the child's experiences with their caregivers in the physical world will help them develop either on the positive or negative side of a characteristic. Infants are completely dependent on others and are learning to either trust or mistrust that others will meet their needs. Crying is the infant's main method of communicating a need and should always be responded to in order to promote trust. Toddlers are trying to master doing things for themselves. They want to dress and feed themselves. No is their favorite word, usually because they want to do things themselves rather than accept help. When toddlers are encouraged to meet their needs, even if they're messy, take a long time, and don't fully succeed, they develop a sense of autonomy. When toddlers are criticized for their imperfect attempts or are not permitted to try things for themselves, they develop shame or self-doubt. Preschoolers focus more on exploring how the world works. They want to investigate everything and ask a lot of why questions, like why is the sky blue and why do whales live in the sea? If preschoolers are encouraged to be inquisitive and investigate their world, they develop initiative. If they're criticized for being too nosy or too busy, they develop a sense of guilt and their curiosity decreases. School-agers are learning to work hard to master a skill. Usually they're working hard in school, but they also could be learning to master a sport or other hobby. If school-agers are recognized for their hard work, they will develop a sense of industry. If they're criticized for not being successful or their hard work is ignored, they can develop a sense of inferiority and avoid working hard on other tasks. Adolescents are exploring their identity and integrating their own values with societal norms and roles. If they can integrate their values and accepted roles, they will develop a sense of identity. If they cannot integrate their values with accepted roles, they may develop role confusion and lack an understanding of themselves. Adolescents are also very concerned with the opinions of their peers, and their self-concept is based on fitting in with peers. These are the stages of Piaget's theory of cognitive development. Infants and young toddlers are in the sensory motor stage where everything they do involves the senses or motor functions. First, they're learning to control their reflexes, such as sucking. At birth, rooting and sucking are reflexive, but within a few weeks, the infant no longer responds reflexively and can control when to suck. As infants interact with people and objects, they learn their physical characteristics, such as what can be thrown, what bounces, what makes a fun crashing noise, and what gets mommy and daddy's attention. As infants learn the properties of their world, they develop a sense of time and space, cause and effect, and object permanence, which is knowing that something exists even when it can't be seen. Older toddlers, preschoolers, and young school-agers are in the pre-operational stage. In this stage, children think illogically. They begin to use symbols, like pictures, words, and numbers, but they also think magically, or make illogical connections between events. For example, if it was raining when a preschooler broke their arm, they may be fearful the next time it rains because they believe the rain will cause their other arm to break. These events are connected by magic in the brain of a preschooler. Children in the pre-operational stage also are very egocentric, focused only on themselves and unable to take the perspective of someone else. Older school-agers are in the concrete operational stage. Children in this stage make logical connections between events they experience directly. They can think backwards from a goal in order to plan how to reach that goal. They also can consider other points of view, but they cannot yet think abstractly. During the adolescent years, children begin to develop formal operational thought. At this stage, they can think abstractly about things they have no experience with. They can analyze thoughts and create new ideas. It's important when nurses interact with children to look for clues that will identify what stages of psychosocial and cognitive development they're in. Knowing their stage of development will allow you to select the most appropriate interventions to help them cope with and improve their health status. Now we'll discuss development by each stage of childhood and how to plan developmental care. The primary developmental care intervention for children birth to 3 months old is to promote trust. Young infants are completely dependent on adults for their care and can only cry to communicate their needs. Because their senses of hearing and touch are well developed, speaking softly in a sing-song voice and using therapeutic touch can be reassuring. All of an infant's attempts to communicate should be responded to in order to promote trust. It's important to limit an infant's exposure to hot and cold temperatures because their internal temperature regulation is poor at birth, and their ability to moderate internal temperature by sweating or shivering has not fully developed. Safe sleep practices should be emphasized to limit the child's risk of sudden infant death syndrome. Safe sleep practices include no co-sleeping and avoiding the placement of blankets, bumpers, pillows, and stuffed animals in the sleeping area. An infant should sleep on a firm mattress rather than furniture or soft cushions. Other safety measures include placing the car seat in a rear-facing position and always holding the young infant when in bathwater. Breast milk is the preferred source of nutrition. Breast milk or formula should not be warmed in the microwave, and the child's gums should be wiped daily with a soft cloth. 4 to 6 month old infants are developing more social skills. They have a social smile and laugh, know their own name, and babble. They also can remember faces, which can result in stranger anxiety when they meet unfamiliar people. Avoiding separating infants from parents and limiting the number of new nurses assigned to an infant can decrease anxiety. Up to this point, infants have been mostly still, but now they're beginning to roll over, stomach to back first, then back to stomach. They also can sit with support and transfer objects from hand to hand. At 6 months old, a cup and solid foods can be introduced. Bottles and cups should not be propped because they can lead to ear infections, aspiration, and cavities. Iron should be added to the diet at 4 months old because iron stores present at birth will have been depleted. Developmental care for this age should still include responding to crying as well as other attempts to communicate, such as smiling and laughing, avoiding separation from parents, and providing toys to hold and explore. At this stage, infants are beginning to develop object permanence, or the idea that something exists even when it can't be seen. This is the beginning of memory. Infants this stage often are surprised when a missing item returns and enjoy searching for hidden items. Motor skills are developing rapidly. This age child is sitting without support, beginning to crawl, and standing with support. The pincer grasp is emerging, and these infants are able to pick up small items. Clearing the play area of choking hazards is important. New foods can be introduced one at a time every 4 to 7 days to determine if the child has an allergy or intolerance. Developmental care for this age should continue to include trust-building responses to communication attempts and opportunities to move about and develop large motor skills. By 12 months of age, the infant's birth weight should triple and birth length should increase by 50%. Object permanence should be completely developed by the end of this stage. Infants love to play hide and seek with toys and peekaboo with people. These older infants are speaking their first words and use gestures to communicate. They enjoy practicing gestures such as clapping and waving. Having mastered sitting and crawling, these infants are ready to stand without support, cruise, or sidestep with support, and take their first steps. This creates new safety concerns. Tripping hazards should be removed and access to stairs should be eliminated. Breastfeeding should be encouraged as long as possible. No more than 30 ounces of breast milk or formula should be given daily. At 12 months, whole milk should replace formula. Developmental care for this age should focus on providing opportunities to move about in the environment and playing turn-taking and imitation games like peekaboo and patty cake. The toddler stage is a period of rapid growth in language and motor skills. Socially, however, the growth is slower. Toddlers are very egocentric. They may play parallel or next to other children, but usually do not interact. They experience a period of stranger anxiety and may regress when hospitalized and around many new caregivers. A transitional item such as a favorite toy or blanket or parents' presence can ease anxiety. Cognitively, toddlers are moving from the sensory motor stage to the pre-operational stage. They think illogically and believe their thoughts affect actions, which is another type of magical thinking. Toddlers are at risk for many injuries. After age 2 or reaching the weight and height limits of their rear-facing car seat, toddlers can use a forward-facing car seat with a harness. Because of their developing motor and cognitive skills, toddlers are at risk for ingesting choking hazards and poisons. Small toys, batteries, and chemicals should be removed from reach. Foods like nuts, dried beans, popcorn, hot dogs, grapes, and hard candy should be avoided. The phone number for poison control should be posted next to the phone. Toddlers will want to feed themselves because they're in Erikson's autonomy versus shame and self-doubt stage. Finger foods should be provided with portion sizes being 1 teaspoon per age and years for each food group: vegetables, fruits, protein, and starch. Breastfeeding should be encouraged for as long as possible. No more than 24 ounces of whole milk should be given a day. And at 2 years old, 2% milk should be given instead of whole milk. Teeth should be brushed twice a day, and the dentist should be seen twice a year. Toilet training is a major event for toddlers. The family has to be emotionally and physically ready to begin training. Emotional readiness indicators are a sense of autonomy and a family committed to a routine and clear communication. Physical readiness indicators include feeling discomfort when soiled, being able to remove clothing, and imitating others. The process of toilet training begins with just sitting on a potty seat or chair and progresses through producing excrement, celebrating success, wiping front to back, and hand washing. Initially, the process of sitting on the toilet should occur at least every 2 hours. Behavior management can be challenging for families of toddlers. A toddler's favorite word is no because they want to assert their autonomy. To limit tantrums, be consistent with routines, set reasonable limits, and provide choices. 2 choices are sufficient for this age. Be careful not to give a choice when there is none. For example, say, which arm would you like to use for your blood pressure, rather than, can I take your blood pressure? If the toddler answers no, you could break trust by obtaining the blood pressure despite the child's refusal. Timeout is an effective discipline technique for toddlers. 1 minute for each year of age is appropriate. In the preschool stage, children grow more slowly. Birth length finally doubles, but they are rapidly developing new social skills. Their egocentricity decreases and they're beginning to share and take turns. Their understanding of cause and effect and time increases, but they still exhibit magical thinking. Because preschoolers' primary way to learn is through play, they should be allowed to play with medical equipment and receive concrete explanations of treatments and illnesses. Nurses can build rapport with preschoolers by playing with them with items such as building toys, picture books, and make-believe props. Because they're more aware of differences between people, preschoolers are more modest and should have their privacy protected. Safety risks for preschoolers include drowning, burns, firearms accidents, and head injuries. Parents are still primarily responsible for maintaining preschoolers' safety and should receive education about helmet use for sports and when to transition from a car seat to booster seat. Preschoolers' appetites may increase and decrease as their growth rate changes. Their average portion size should be 1 tablespoon per year of age for each food group: vegetables, fruits, protein, and starch. They should have all their deciduous or baby teeth and brush twice a day, floss once a day, and see the dentist for cleaning every 6 months. Toilet training should continue in the preschool stage. Daytime dryness should be achieved by 3 years old and nighttime dryness by 5 years old. If a child is not trained by 5 years old, refer the family to the pediatrician. Timeout is still an effective behavior management technique in this age group. 1 minute per year of age is appropriate. However, preschoolers are still developing a sense of time and will need to be told when the timeout is over. School-age children experience slow growth overall, but accelerated growth in the arms and legs. Girls will have a growth spurt before boys. Because bones are growing faster than muscles and ligaments, school-agers are prone to fractures. Puberty also may begin in this stage. School-agers are in Erikson's industry versus inferiority stage and are learning to work hard at school and hobbies. Staying in touch with teachers and peers is important when they're ill. Explaining and showing treatments and equipment is helpful because school-agers are in the concrete operational stage of cognitive development. Accidents are the main safety risk for school-agers. Sports and firearms safety, as well as proper use of booster seats, should be discussed with school-agers. They also should be taught how to determine if a stranger is a risk and how to seek help when needed. Role-playing is an effective way for this age child to practice teaching about strangers and peer pressure-related situations, such as being introduced to cigarettes, drugs, or alcohol. This is an important age for establishing lifelong habits, especially related to nutrition and exercise. Healthy habits should be emphasized and body mass index should be assessed regularly. Being overweight increases the risk for diabetes, hypertension, and high cholesterol. Referral for a nutrition consult should be initiated when the child's BMI is greater than 25 or the 85th percentile for age. School-agers have developed a new understanding of right and wrong, and timeout is no longer as effective for behavior management. Early in this stage, they see things as either right or wrong, but later in this stage, they can take the perspective of others and consider intent when determining if something is right or wrong. Discussing the child's behavior and motivation can help determine appropriate consequences. During adolescence, the trunk grows rapidly and secondary sex characteristics appear. Both boys and girls are coping with physical and emotional changes. Their thinking becomes more abstract and focused on the future. They may daydream to explore their identity and future goals and begin to show independence from their family. Breast development begins around 9 years old and is completed after the first menses, which will occur in the adolescent stage for many girls. Puberty for boys starts with testicular enlargement, which may begin in the late school age or early adolescent stage. Socially, teenagers are preoccupied with fitting in with their peers. In a healthcare setting, normal findings should be emphasized and normal routines should be encouraged. Peer interaction and independence also should be supported. Adolescents often engage in high-risk behaviors and do not believe they will suffer any consequences. It's important to be objective and non-judgmental when talking with teens so they feel comfortable sharing information about their health. Maintain their privacy and confidentiality by interviewing them away from parents, but explain that information about dangers to themselves or others will be shared. Information about reproduction, such as pregnancy, birth control, and sexually transmitted infections, can be kept confidential at the adolescent's request. The HEADS assessment is an acronym to guide interviews and assess adolescents for health risks. Ask open-ended questions about the home environment, education, employment, peer-related activities, drug use, sexuality, suicide and depression, and safety. Because 25% of sexually active teens have sexually transmitted infections, all sexually active teens should be tested for infections. Sexually active girls should be tested for pregnancy. All teens should receive the human papillomavirus vaccine per the immunization schedule published by the Centers for Disease Control and Prevention. Gender identity should also be discussed with adolescents. Suicide is the third leading cause of death for adolescents. Teens should be screened for depression and suicidal ideation and planning. The primary cause of mortality and morbidity for teens is motor vehicle crashes. Driving safety and distracted driving risks and prevention should be discussed with all teens and families.